Welcome to the Deep Dive. If you're a medical student prepping for rotations, a resident, or just a dedicated learner trying to master one of the most demanding fields in medicine, you know how vital the core texts are. Today we're doing a critical deep dive into the absolute foundation of cardiac surgical practice, straight from the manual, Cardiac Surgery Operative Technique, 2nd edition.
That's right. And our mission here isn't just to, summarize. It's more of a precise extraction of the key operative principles.
So translating the textbook page into what it actually looks like in the OR.
Exactly. We're focusing on the real nuts and bolts, the surgical access, the really high-stakes anatomical relationships, and the step-by-step mechanics of some pretty complex repairs. We want to give you the why behind every single move.
And this particular source, I think what makes it so indispensable is its visual philosophy. The illustrations are all presented from the surgeon's point of view.
Which is everything.
It's the ultimate shortcut to understanding those tricky 3D relationships, turning these complex maneuvers into something concrete, something you can actually visualize.
It really is like being handed the keys to the OR before you've even scrubbed in. So let's start with that view. The very first challenge, getting access and getting oriented.
Okay, so picture this. The patient is supine. The surgeon's making a standard mid-sternal incision, usually standing on the patient's right side. From that specific vantage point, what do you see first and what's still hidden?
Right. So from that right-sided approach, your view is completely dominated by the right heart structures and the great vessels. You're looking right at the superior vena cava, the right atrium, the right ventricle, main pulmonary artery, and the aorta.
All the big players right up front.
All the big players. But, and this is critical, you have to realize what you can't see. Only a tiny, tiny sliver of the anterior wall of the left ventricle is naturally visible.
So if your target is actually on the left side, say the left atrium or the pulmonary veins, you have to do something to get a better look.
Precisely. You need to expand your field of vision. If you need to access the left atrium or the origins of the right pulmonary veins, you get that exposure by strategically displacing the right atrium medially.
Just moving it out of the way.
That simple displacement makes all the difference. It opens up your view to those posterior structures.
Let's shift from that wide view to the microanatomy, specifically the relationship between coronaries and valves. In cardiac surgery, being close often means being high risk. So what's the most high-stakes intersection point?
We have to talk about the fibrous center of the heart and this critical intersection called the crux.
The crux.
So you have the right coronary artery, the RCA, which runs in very close relation to the tricuspid valve annulus. Then a bit further down, the distal RCA, which is what supplies the AV node tracts near the mitral valve annulus.
And the crux is right at that junction.
Yes. The crux is defined as the cross point of the atrioventricular septum and the atrioventricular groove. And the surgical implication here is, well, it's profound.
Because the AV node is right there.
Exactly. Any misdirected suture, any incision during a tricuspid or mitral repair right at that spot puts the patient at immediate risk of complete heart block. It's probably the highest risk anatomical spot in that whole posterior region.
Wow. That really transforms the crux from just a textbook term into a boundary you just cannot cross.
You can't.
Staying with the mitral valve for a moment, the biomechanics are just incredible. How does the morphology, the size difference between the leaflets, allow it to do two completely different things in diastole and systole?
It's a masterpiece of efficiency, really. During diastole, when the heart is filling, the anterior leaflet moves anteriorly, which is a bit counterintuitive. It moves toward the left ventricular outflow tract.
You open things up.
Right, to maximize the funneling of blood into the ventricle. Then during systole, the whole system just reverses.
That's what happens.
The anterior leaflet swings back to meet the posterior leaflet, closing the orifice to stop any regurgitation. But, and this is the genius part, it does this while simultaneously opening the LV outflow tract wide open for ejection into the aorta.
So it's closing one door while opening another.
Perfectly put. And the quantitative detail is key here. The anterior leaflet does most of the moving, but it only makes up about 1/3 of the annular circumference. The posterior leaflet is attached to the other 2/3.
So the posterior leaflet is more of a stable wall?
It's the stable supporting wall, exactly, while the anterior leaflet does all the heavy lifting.
So we've established the internal complexity. Let's go back to that very first step, the mid-sternal incision. Beyond just, making the cut, what are the critical safety principles when you're using the sternal saw?
Well, the standard incision runs from just below the sternal notch down to the xiphoid. And while there's a trend for shorter, more cosmetic incisions, we have to stress that never trumps the need for adequate exposure.
Function over form.
Always. Now, for the sternotomy itself, the moment you use the saw, a couple of things are just non-negotiable. First, you stop ventilation for a moment.
You stop the breathing.
Mhm.
Why?
It forces the lungs to deflate and pull away from the back of the sternum. It creates a margin of safety. Second, when you use the saw, you hold it firmly, and that protective toe guard on the tip has to be kept pressed hard against the posterior table of the sternum.
So it can't slip and go deeper than the bone.
Exactly. It prevents the saw from plunging and injuring anything underneath. After that, once it's open, you manage hemostasis on the bone edges with electrocautery, but you also supplement that with a thin layer of bone wax or maybe gel foam.
Okay, that makes sense. Let's move into establishing circulatory support. This means cannulation. For a standard arterial cannulation in the ascending aorta, what are the steps?
The first thing is placing a secure purse-string stitch, usually a 30 polypropylene, in the aortic wall. This stitch does two things. It secures the cannula, and it lets you seal the hole tightly when you take it out.
And for getting the cannula in.
You have to align the bevel of the cannula perfectly with the incision. Often the surgeon will slide their thumb aside or use forceps to pull the adventitia open.
What if there's resistance? You can't just force it.
Absolutely not. You never force it. You can gently pass a tonsil clamp into the aorta to dilate the opening a little bit, ensure a smooth entry, and then try again.
Now let's talk alternatives. The femoral artery. That seems trickier because you have to direct the tip. What's the maneuver there?
It is trickier. You initially insert the cannula with the bevel facing the back wall of the artery. Then as you advance it up the vessel, you do this sort of twisting motion to bring the bevel to face anteriorly.
And what's the big life-saving warning that comes with femoral cannulation?
The warning is this. Advancing the cannula against any resistance is extremely hazardous. If you start the flow and see excessively high perfusion pressures, that is an immediate emergency.
What does it mean?
It strongly suggests an arterial dissection or that the cannula tip is jammed against the vessel wall. You have to stop the flow immediately and figure it out.
That is a high-stakes moment. Now, the axillary artery is often seen as a safer, more strategic option. What are its advantages?
The right axillary is often preferred for complex archwork for two big reasons. First, you can establish full arterial perfusion before you even do the sternotomy. That de-risks the whole procedure, especially in redos.
And the second reason?
For arch surgery, this is crucial. It lets you keep perfusing the right common carotid artery, maintaining blood flow to the brain, even during periods of circulatory arrest.
So if you're using the right axillary for inflow, you can't monitor pressure on the right arm.
That's right. You have to use the left radial or brachial artery for reliable pressure monitoring.
Okay, support is established. Now, myocardial protection. Cardioplegia. What's the preferred method?
Antegrade cardioplegia, delivered right into the aortic root. That's the go-to technique, but, and it's a big but, only if the aortic valve is competent.
And what are the targets?
You're targeting an infusion pressure of about 80 to 90 millimeters of mercury mean. But beyond delivering the solution, there's one step the manual stresses is absolutely mandatory. The left ventricular vent. In all cases, the LV must be actively vented. If that ventricle distends, you can cause significant muscle damage. The vent prevents that.
That brings up a good point about advanced support. For a system like the tandem heart, what makes it so unique?
The tandem heart is a percutaneous left atrium to femoral artery bypass. What's fascinating is the cannulation. The venous cannula is advanced through the atrial septum directly into the left atrium.
Into the left atrium, so it's pulling blood that's already been through the lungs?
Exactly. It's uptaking fully oxygenated blood. And because of that, an external oxygenator is not required for this specific system.
That is a brilliant distinction.
Yeah.
Okay, let's move into specific operative techniques, starting with congenital aortic valve stenosis. What's the goal with a valvuloplasty there?
The goal is to be restorative. You carefully incise the fused commissures all the way to the wall of the aorta, but the tricky part is not going too far, because that would just create an incompetent, leaky valve.
How do you check your work in the OR?
Two ways. First, you flood the aortic root with saline to watch the leaflets coped and make sure they seal. Second, you calibrate the opening with Hagar dilators to make sure it's big enough but not too loose.
Okay, now for subaortic obstruction. This often means resecting a hypertrophied septum, which is dangerous territory because of the conduction system. Where is the absolute safety line?
This is one of the highest risk maneuvers. The area of excision has to be located strictly anterior to the membranous portion of the ventricular septum. The bundle of his runs right near there, so that's the danger zone.
So practically, what are the visual boundaries for that safe zone?
The safe zone runs from the commissure of the left and right coronary cusps of the aortic valve down to the mid portion of the right cusp. You stay within those lines, well, anterior, and you protect the conduction system.
And when a standard myotomy isn't enough, you escalate to the Connorstan aortoventriculoplasty. When is that indicated?
That's reserved for when you need to widen the LV outflow tract by more than, say, 2 to 4 millimeters. This often comes up in small children who need a prosthetic valve that's big enough to support their future growth.
And the procedure itself sounds incredibly disruptive.
It's a radical rebuilding. The incision goes from the aorta, crosses the annulus, and continues right into the right ventricular outflow tract and septum. Then you reconstruct and enlarge the whole thing with a diamond-shaped Dacron patch.
Finally, in this section, mitral valve replacement. When is repair just not an option?
Replacement becomes necessary when repair is, well, impossible or just unlikely to work long term. Two main reasons. Rheumatic type disease, where the leaflets are thick and calcified.
And they just don't move well.
Right. Or the myxomatous degeneration type, where they show this marked hooding and there's just not enough good tissue left to work with. If you can't get reliable closure, replacement is the safer bet.
Perfect. Let's move to some more advanced procedures. For something like residual coarctation stenosis, you often use an extra anatomic bypass graft. What's the best route for that graft?
Right. So for that bypass, the key decision is the routing. It's typically placed posterior to the inferior vena cava.
Why posterior?
Two reasons. It's the shortest route, and more importantly, it minimizes the risk of the graft getting compressed by other structures in the mediastinum, which is a big worry with anterior routes.
And for atrial fibrillation, there's the Mays third procedure. What's the goal of creating these blind passageways?
The goal is to force an orderly passage of electrical impulses, straight from the SA node to the AV node. You create these linear scars, the blind passageways that stop the electrical impulses from scattering and creating those chaotic reentry cycles of AFib.
The modified procedure uses radiofrequency ablation. Does the tissue type matter for that?
Oh, absolutely. It's less reliable in thick, fatty septal tissues. The energy just doesn't penetrate as well, but it's much more reliable in thin atrial tissues, like around the pulmonary veins and the AV valves.
And are there specific spots where you use cryolesions, the cold therapy?
Yes, there's a very specific starting point, the tricuspid annulus. A 3-millimeter cryolesion is placed there for 2 minutes at negative 70 degrees Celsius. It creates a very reliable lesion to break the circuit.
Let's wrap up with the most common cardiac tumor, the left atrial myxoma. Why is that operation always considered urgent?
It's urgent because myxomas are friable. They're crumbly. That means they have an extremely high risk of breaking off and causing a systemic embolization, stroke, or just blocking the mitral valve.
And how do you repair the hole left behind after you take it out?
You have to excise the tumor's attachment point completely. The defect that leaves in the atrial septum is then typically repaired by suturing in a pericardial patch to restore the wall's integrity.
So if we tie all this together, what we've really explored today is the meticulous foundation for safe cardiac surgery.
It is. We've gone through the how and the why behind so many of these maneuvers, from defining the crux to understanding the dangers of femoral cannulation and the sheer complexity of something like the Connorstan.
And understanding these details, like the 13 to 23 ratio of the mitral valve leaflets or exactly where to cut in a septal excision, that's what transforms clinical knowledge into real practical insight.
Exactly. So to reinforce some of what we covered, here's a critical question for you to think about. During a septal myotomy for subaortic stenosis, what specific anatomical landmark must the surgeon strictly avoid? And how is the safe excision area positioned relative to that structure to protect the heart's conduction system?
A great question to ponder.
Think about those conduction pathways and try to mentally trace that safe route we talked about to really solidify the image in your mind.